Hey guys, this is Aaron with Ross Training Academy, back with another video. This video is just going to be about basic first aid. It's not going to go super in depth or super complex with anything. It's just going to be the general basic first aid that everyday people can use. So with first aid, there's some initial steps that you want to take care of and make sure happen before you kind of continue on with your care. The first thing is just going to be calling 911 or calling for help. You're going to be the one that knows how to do this basic first aid, so you don't necessarily want to be the one calling 911. You might just have to delegate or designate somebody that you're with to call 911 for you or for the patient. The next thing, you just want to make sure that your scene is going to be safe for yourself, for the people you're with, and for the patient. If it's not safe for yourself, just go ahead and leave. We're going to try to take the patient, try to take everybody with us, but at the end of the day, we have to worry about ourselves. We have to be able to save ourselves, because if we're hurt, we just kind of add to the problem and not to the solution. So make sure that you're safe. And so some things to consider are, was it a dog bite? Is the dog still around? Was it a snake bite? Where's the snake at? We're not going to go hunting down the snake. We're not going to try to kill it and bring it to the hospital with us. Nothing like that. We're just trying to figure out where it's at so that we can be away from it. If it's a traffic incident, do we want to get out off the highway or out in the middle of the highway and render aid? Do we have a safety vest? Is there another vehicle that can block for you just so that another accident doesn't occur? Just little things like that to think about when these incidents happen. And then the last thing that we want to start thinking about is going to be BSI, or body substance isolation, and PPE or PPE, personal protective equipment. And so some things that would count as personal protective equipment will be something like a mask, goggles, gloves, a gown, just stuff that's going to isolate yourself from the patient. You don't necessarily want to be touching their blood. You don't really want them coughing and sneezing on you. It kind of goes back to keeping yourself safe. So now we're just going to go ahead and start talking about the first aid type of stuff. The first thing that we're going to talk about is going to be a heart attack or cardiac arrest. A lot of times these two terms are used interchangeably, but they do mean different things. So they shouldn't really be used interchangeably, because that can cause some confusion. So a heart attack. Most likely the patient that is suffering from a heart attack will be conscious. They will be breathing. They might even be talking with you. They will have a pulse. They might just be having some center crushing type chest pain or pressure to the center of their chest. This pain might radiate to their to their left arm. They might have some left arm numbness, pain, tingling. They might have some left-sided neck and jaw pain, numbness, tingling. They might be lightheaded. They might have a headache. They might be dizzy. They might be nauseous. They might be vomiting. Their skin's probably going to be very diaphoretic, very sweaty. These are all going to be some signs of a heart attack. Now, if we think that somebody's having a heart attack, the first thing that we want to do is we want to call 911 and just let them know what's going on so that we can start getting help on the way. And then if we think somebody's having a heart attack, we want to give them 324 milligrams of chewable baby aspirin, or just 4 tablets of chewable baby aspirin. Let them chew that stuff up, swallow it, maybe consider giving them like a little just sip of water just to get that chalky taste out their mouth. But that's about it. I will say something to consider is to think about where you're at. If you're an hour outside of town, 2 hours outside of a town, outside of an EMS service, and you're calling 911 and they're saying it's going to be 45 minutes, an hour for an ambulance to get there, maybe talk with that dispatcher and see where that ambulance is going to be coming from, and maybe try to rendezvous with that ambulance. Get that patient in your car, and you're going to just drive towards that ambulance or drive towards that town while the ambulance is also coming towards you. That'll cut that hour time down to about half an hour. But of course, talk with the dispatcher, the 911 dispatcher, and they'll be able to kind of further assist you with what to do. Now, a cardiac arrest, on the other hand, this person is going to be unconscious, unresponsive. They will not be breathing. They will not have a pulse. Their skin will be pale, cool, and dry. Their eyes will probably be dilated. Their pupils are going to be really large. These are all going to be some signs of a cardiac arrest. Now, if somebody's having a cardiac arrest, we're going to start doing our CPR, our chest compressions, and calling 911. Now, I have a whole nother video on how to do like BLS CPR, so go ahead and check that out. This isn't the video for that. But that's about it for this one. Let's keep going. Heat emergencies. Depending on where you live, heat emergencies are going to be more common than other places, but people can suffer from heat emergencies everywhere. Even somebody in a sauna could suffer from a heat emergency. So let's go ahead and talk about them. There is a third heat emergency that I don't have up here, and it's just going to be heat rash. We're not too concerned about that one. We do want to get that person, start cooling them down, getting them away from that hot environment, but it's not necessarily an emergency at that point. When it starts to become an emergency is when you start seeing heat stroke, or I'm sorry, heat exhaustion. So with heat exhaustion, the person is going to be awake, they're going to be alert, talking to you, they're going to be just sweating profusely, severely diaphoretic. They're going to have a rapid, weak pulse if you feel for their pulse. They're going to have muscle cramps just because they're dehydrated. They're going to have dark urine because they're just dehydrated. They might even start feeling a bit dizzy. Their temperature at heat exhaustion levels is typically going to be right around 100 to 103.9 degrees Fahrenheit, somewhere around there. Now, if we believe somebody's suffering from heat exhaustion, what we want to do is get them into a cooler environment, get them away from the heat source, maybe start taking off their clothes, give them cool water, maybe even get them in the shade if you're not in a cooler environment, and call 911. That's what we're going to do for them. Now, heat stroke, on the other hand, they're going to have very similar symptoms as the heat exhaustion, but when it starts turning into a heat stroke, you're going to start seeing confusion, or they're going to go unresponsive. They're going to stop urinating. They're going to have dry skin. They're just so dehydrated they can't keep sweating anymore. Their temperature is going to be at about 104 degrees Fahrenheit and above. Now, if we start seeing heat stroke, we're going to do all the same things that we did for heat exhaustion, but now we're also going to start using ice packs, cold packs, putting them at the junctional sites, so at the neck, the armpit, the groin, really trying to cool off those big blood vessels to cool the blood that goes around the body. We might even consider doing like a cold plunge for this person, get an ice bath, and we're going to put this person in that cold ice bath. And so that's about it for the heat stroke, heat exhaustion, heat emergencies. Let's keep going. All right, so an EpiPen. We're going to use an EpiPen for an anaphylactic reaction and or if there's any respiratory involvement. So an anaphylactic reaction is going to be an allergic reaction that involves two or more body systems. So think about all the body systems that you have, that a person has, and if there's two or more involved, it's going to start transitioning from just a regular allergic reaction to an anaphylactic reaction. And an anaphylactic reaction is when we're going to start using an EpiPen. So if you see somebody who consumed their allergen or is around their allergen and they start having and they're nauseous, that's going to be two or more body systems, and so we can start using the EpiPen at this point. Let's say a different scenario, that person was around their allergen and all they have is a rash. Then we don't have to use their EpiPen. We can start with something as simple as Benadryl and try to kind of reverse that reaction. The adult dose for Benadryl is going to be about 50 milligrams, and then for a pediatric, it's going to be about 12.5-ish to 25-ish milligrams. Now, don't take these milligrams by heart. Consult with your doctors first. With that being said, if there's a respiratory involvement and there's a known allergen or allergy to something, and they were around that allergy, consume that allergen, we can go ahead and just give the EpiPen, even if it's only the respiratory involvement. We don't need to have two or more body systems involved if it's a respiratory complaint. So if they're just saying it's hard to breathe, you hear wheezing, it feels like their neck's closing up, their throat's closing up, go ahead and just give them the EpiPen. Now, the adult dose for the EpiPen is going to be 0.3 milligrams, and the pediatric dose is going to be about 0.15 milligrams. These are going to be specific to each patient, but this is just kind of like the general dosage that comes in the EpiPens. The way we're going to use the EpiPen is we want to do what's called blue sky, orange thigh. And you can see here, they're pulling it out the package. They pull off the blue cap. Then they're going to take this orange part and stick it to the lateral thigh, the outside of the thigh. And it can go through clothing. And they would have this blue cap off. Now, I will say, I don't recommend putting your thumb over top of this blue cap or you're going to take the blue cap off, but I don't recommend you putting your thumb over top of where the blue cap was, simply because if by accident you just somehow happen to flip this thing around backwards and you put your thumb over top and it's actually over top of the needle side, that needle is about 1.5 inches long and it will go through your thumb and even into and through your thumb bone. So I just don't recommend putting your thumb over top. I recommend just wrapping it around the rest of your hand. But blue sky, orange thigh, and that's how you do it. So that's EpiPens. Now let's talk about envenomation. So this is going to be things like snake bites, insect bites, even jellyfish stings can kind of be a part of this. If this does happen, you do know that this happened to your patient. We're not going to take the insect or the animal with us to the hospital. If you can safely take a picture of it maybe, but that's about it. The hospitals don't necessarily want you taking these with. But of course, like with all of these first aid treatments, calling 911 is going to be the first thing to do. So talk with the 911 dispatcher, see what they want. Anyway, with this being said, we are not going to put a tourniquet on the extremity. We're not going to makeshift the tourniquet, nothing like that. We're not going to suck the venom out. It's not possible. We're just not going to be able to do it. What we want to do is we want to try to keep it clean. We want to try to irrigate the wound with sterile water or sterile saline and just kind of rinse it out. And then we're going to bandage it with a dry, sterile dressing or a Band-Aid, something similar, something that comes in a sealed package. Now, if it's something like a jellyfish sting or even like a man-of-war sting, something like that, warm water is what we're going to do, kind of submerge the area in warm water or get a warm towel, set it over top, warm gauze, sterile gauze, set it over top of where the sting was. We're not going to have to pee on it or anything like that. Just the warm water, warm salt water will work great. And then wherever they were stung or bit, we want to take a Sharpie, take a marker, and draw around the initial swelling, whatever we believe is the initial swelling, and then we're going to mark the time that we wrote that circle around that initial swelling. That's just to be able to show that there was swelling, what time it started, and then if the swelling gets worse, we're able to kind of track how fast that swelling is growing because you wrote the time down that you wrote that initial circle around the wound, around the swelling. I hope that made sense. But yeah, that's really all we're going to do for this. Call 911, get into a hospital, and that's about it. Now we have burns. So there's going to be 3 main types of burns. We're going to have type 1, superficial, type 2, partial thickness, type 3 is full thickness. The type 1 is going to be more of like that red sunburn type of look. The type 2 can happen from a sunburn, but any type of burn can cause a type 2. And it's going to look like the sunburn. There's going to be that sunburn there, that redness, but now we're also going to start seeing blisters forming over that burn. A type 3 or that full thickness burn is going to have a 1st degree and a 2nd degree. So we're going to see the sunburn redness and the blisters, but now we're going to start seeing the muscle layer, the tissue underneath the skin, potentially even the bone. And that's when we're going to start considering or saying that's a type 3 burn. If somebody is burned, what we want to do is initially stop the burning process, get them away from that burning source. If it's a chemical on them, brush that chemical off with a towel, a dry towel. We don't want to use anything wet just because some chemicals can be water reactive and that'll worsen the burning process. So just dry, brush whatever's burning off. If it was a fire, move them away from it. Hot stove, move them away from it. Then we want to remove restrictive clothing. So we want to take off, necklaces, rings, bracelets. If any clothing is melted to the skin, we want to try to remove as much as we can, but we don't want to pull any out of the skin. We're going to wait for it to be done at the hospital. And then we just want to keep it dry, keep it sterile. So after we brush the chemical off, stop the burning process, get the clothing off, take a dry, sterile dressing, dry, sterile bandage, and just wrap it over top the wound. And that's all we're going to do. It is not recommended to submerge an area in ice water just because the skin is what thermoregulates or regulates your body temperature. So when you don't have your skin anymore and you start submerging in ice water, you might start causing frostbite to that area. And so now we have a burn and frostbite. We can consider using ice packs, cold packs, but we don't want to place it directly on the skin. We want to wrap it in a towel, wrap it in paper towels, napkins, and then place it over top of the burned area. And of course, call 911, get him to a hospital. But all right, moving on. So, wound care. You got an abrasion, road rash from a car accident, you fell off the swing, just things like that. Just basic wound care. What we're gonna do first is just pull out any larger debris. So try to pull out any rocks, any leaves, get it off of the open wound, the open skin. We're then gonna irrigate it with sterile water or sterile saline and just kind of wash out any debris that we can. We're not gonna use rubbing alcohol. We're not gonna use peroxide. Just sterile water, sterile saline. Of course, 911, get into a hospital, listen to the dispatcher, listen to your doctor, whatever they recommend. And then we're also going to use like sterile cotton swabs or sterile gauze soaked in that sterile water, sterile saline, and just kind of dab and rub the area and try to get as much debris out as we can. If not, hopefully all of the debris out. Then we're just going to cover with a dry sterile dressing and then secure that dressing to that open wound. So use tape, use more bandaging, and just secure that dry bandage over top of the wound. And then we want to be able to change that dressing. We want to do it at least once or twice a day with a cleaning in between each change. Or anytime the bandage gets wet, we want to take it off, let the skin dry a little bit underneath, and then do that same cleaning process before we wrap it up again. And that's basic wound care. Now we have hypothermia. So hypothermia is going to be a temperature at or below 95 degrees Fahrenheit. So somebody's just really cold. That's hypothermia. Maybe it's from a pool. Maybe they were in the ocean. Maybe they were in an avalanche. Maybe they were skiing. Maybe they were just homeless and they live outside and it's really cold outside and now they're suffering from hypothermia. You never know what might happen. So the first thing we want to do is remove them from that cold environment. Get them into that warm car, that warm building. We want to get their wet clothing off. So even if that means they have to get naked, as long as they're in that warmer environment, take all the wet clothing off. And then we want to start considering placing hot packs, warm packs at the junctional sites. So the neck, the base of the neck, the armpits, the groin, warm up those larger blood vessels. And then we want to start using larger blankets to cover up the patient. Even consider like those mylar foil type blankets, rescue blankets, and that really will help keep some of that heat in. And we're just gonna warm this person up. Call 911, get him to a hospital. Their hands are gonna be real cold, their feet are gonna be real cold. We don't really want to start rubbing those areas with our warm hands. It's something that we always do, but we don't really want to do that because we might break some cells that are inside of that skin. Just from those cells being frozen, we might start breaking those inside. So we don't necessarily want to do that. And then as the person starts getting colder in temperature, so below that 95 degrees Fahrenheit, we don't really want to jostle their body around. We want to do very slow, smooth motions. If we start jostling their body around, we might throw them into a lethal heart rhythm, and that's not something we want to have to deal with. So just try not to move them around too much, or at least not vigorously. But that's about it for hypothermia. All right, so now we have splinting. We're going to splint fractures or dislocations. We want to use a rigid board or even cardboard or a book, something hard, sticks even if you're in the middle of nowhere and that's all you got. Just some sticks, just something rigid. We want to immobilize that extremity in the position of comfort, but we also want to attempt to put it into its natural position. So how would that extremity naturally be? We want to try to get it back to that point. If that's going to cause extreme pain, don't do it. Call 911, get him to a hospital, splint it how it is. Preferably, we want it to be in that natural position, that natural body position, but immobilization in the position of comfort is also just okay. For a fracture, we want to make sure we secure the joint above and below the fracture. So something like this here, we're going to say that it's the mid forearm, the radius ulna that's fractured. We want to make sure we immobilize the wrist joint and the elbow joint, and that'll help to immobilize the fracture in the mid forearm. Now, if we have a dislocation of a long bone or just a bone, if we have a dislocation of a joint, we want to immobilize the long bone above and below that dislocation. So we can say something like over here, like that. We can take the knee or the foot, either one. Let's say that the knee is what's dislocated right now. We're going to try to immobilize the lower leg, the lower long bones, the tibula and fibula. And then we're also going to try to immobilize the upper leg, the upper thigh, that femur. And that'll help immobilize the knee bone and stop that from moving. And then, if you see an open wound over top of the fracture, we're going to splint that. We're still going to splint the extremity the exact same way. We're not going to try to push that bone back in. We're not really going to move their arm around too much. Just kind of splint it how it is at that point. And then we're going to treat the open wound, make sure it's clean, wrap it in a bandage, and that's it. I will go back real quick. I have another video for bleeding control. And so if you want to learn more about bleeding control, go ahead and watch that other video. This video isn't necessarily for that.
All right, so now we're just going to go ahead and talk about seizures. The most significant one, or the one that we're going to be used to seeing, is going to be that tonic-clonic or that grand mal seizure, just that full body type of shaking type of seizure that we're used to seeing in movies even. For this one here, I'll be honest, at the first aid level, there's not a whole lot that we're going to do for this person. We're going to stop them from hurting themselves. So all that looks like is getting them down on the ground. We're going to move everything that they could run into while they're having their seizure, just so they don't hurt themselves. We're going to put a pillow underneath their head or just hold their head so they aren't smacking it on the ground. We are not going to restrain this person. We're not going to try to hold them down. We're not going to try to wedge something in between their mouth, in between their teeth. If their jaw's clenched, we're not going to do this especially because if we start trying to pry their mouth open and we break some of their teeth and they go down into the mouth, well, their jaw's clenched, we can't get their mouth open, and so now we just potentially caused a choking hazard. So honestly, we're just going to kind of let their seizure happen, stop them from hurting themselves, and that's about it. Some things that we're going to try to do is we're going to try to time the seizure duration. So just time it with your phone, look at the clock, just see how long the seizure is occurring. And then you want to start timing it once it stops. And if it starts again, you want to time the distance between those two seizures. So is it 30 seconds between their last look of seizure-like activity to their new look of seizure-like activity? Was it 30 minutes from that last look to the new look? You know, what's the time between it? And that's it. That's really all we're going to do for these people having seizures. Call 911. Don't let them hurt themselves. Try to get them to a hospital. And then, strokes. We do have another video that we're going to make that is all 4 strokes. So just be on the lookout for that one. But yeah, that's it for this video. That is just very basic first aid. Thank you guys for watching. Take care. Bye.